This video is going to demonstrate how to use a goniometer to measure the range of motion for shoulder flexion. When measuring shoulder flexion, the goniometer is moving in the sagittal plane. The normal value is 0 to 180 degrees. For shoulder flexion, the patient is going to be hook lying. So we are going to have her bring her hips and knees into a little bit of flexion. And then I'm going to ask her to flex her shoulder. The fulcrum of the goniometer will be placed at the axis of motion. The stationary arm of the goniometer will be in line with the lateral midline of the thorax, and the moving arm will line up with the lateral epicondyle. Can you please bring your arm up over your head as far as it will go? The patient has 154 degrees of shoulder flexion, which is normal. This video is going to demonstrate how to use a goniometer to measure the range of motion for shoulder abduction. When measuring shoulder abduction, the goniometer is moving in the frontal plane. The patient is going to be lying in the supine position. Shoulder abduction occurs in the frontal plane. The normal value for shoulder abduction is 0 to 180 degrees. The patient's palms will be facing up to the ceiling. Please slide your arm along the bed towards your ear to keep it along the bed. The fulcrum of the goniometer will be placed at the axis of motion, which is pretty much in line with the axilla. The stationary arm is going to be parallel with the midline of the sternum, and then I'm going to move the moving arm up to line up with the medial epicondyle of the humerus. The patient has 163 degrees of shoulder abduction, which is normal. This video is going to demonstrate shoulder extension range of motion using a goniometer. Shoulder extension occurs in the sagittal plane. The normal value is 0 to 60 degrees. The patient is going to be in the prone position. The patient's palms are going to face her body, and it is okay if her elbow remains in a little bit of flexion. The instructions are for the patient to bring her arm up above the bed as high as she can. The fulcrum of the goniometer will be lined up with the greater tubercle of the humerus. The stationary arm is going to be lined up with the lateral midline of the thorax, and the moving arm is going to be in line with the lateral epicondyle of the humerus. The patient has 56 degrees of shoulder extension, which is normal. This video is going to demonstrate shoulder internal rotation using a goniometer. The normal value for shoulder internal rotation is 70 degrees. The patient is still going to be in the supine position. The fulcrum of the goniometer will go over the electron process of the ulnar. The stationary arm is perpendicular to the floor. The moving arm lines up with the ulnar styloid process. The patient has 70 degrees of shoulder internal rotation, which is normal. This video is going to demonstrate shoulder external rotation using a goniometer. In anatomical position, shoulder internal and external rotation occur in the transverse plane. But in our testing position, internal and external rotation are going to occur in the sagittal plane. The normal value for shoulder external rotation is 90 degrees. The patient is going to be in the supine position. She is going to have 90 degrees of shoulder abduction and 90 degrees of elbow flexion. For shoulder external rotation, can you bring your hand all the way back towards the floor? It is important to make sure that she maintains 90 degrees of elbow flexion and that the bed is not in her way. The fulcrum of the goniometer will go over the olecranon process of the ulna. The stationary arm is perpendicular to the floor. The moving arm lines up with the ulnar styloid process. The patient has 87 degrees of shoulder external rotation, which is a little bit below average.
For shoulder flexion and gravity resistance, I will place the patient in the seated position and assess their range of motion. I will then palpate the anterior deltoid coracobrachialis over the proximal anterior aspect of the humerus. Then I will perform flexion while raising the arm to 90 degrees, stabilizing their ipsilateral shoulder. I will apply increasing resistance over the distal humerus in the direction of shoulder extension. For shoulder flexion and gravity elimination, I will place the patient on their side. I will then stabilize their ipsilateral shoulder again, and I will palpate the same anterior deltoid coracobrachialis over the proximal anterior aspect of the humerus. For shoulder extension and gravity resistance, I will place the patient in the prone position and their arm will go fully internally rotated. I will assess the range of motion and stabilize the ipsilateral thorax while palpating the teres major. I will then apply increasing resistance to the distal humerus in the direction of shoulder flexion. For shoulder extension and gravity elimination, I will place the patient on their side and I will stabilize their ipsilateral thorax while palpating the teres major muscle. For shoulder abduction and gravity resistance, I will place the patient in the seated position and assess their range of motion with their arm at 90 degrees and palm down. I will then stabilize the ipsilateral shoulder and palpate the middle deltoid supraspinatus at the superior lateral aspect of the humerus. I will apply increasing resistance of the distal humerus in the direction of shoulder abduction. For shoulder abduction and gravity elimination, I will place the patient in the supine position with their arm at their side. I will then stabilize the ipsilateral shoulder and palpate the middle deltoid supraspinatus again. For shoulder abduction of the scapular plane with gravity resistance, I will place the patient in the seated position and assess their range of motion with their thumb facing upward. I will then stabilize the ipsilateral shoulder and palpate the supraspinatus over the supraspinatus fossa, and apply increasing resistance of the distal humerus in the direction of shoulder adduction. For shoulder internal rotation with gravity resistance, I will place the patient in the prone position with their head rotated contralaterally to the side. I will then assess the range of motion at 90 degrees and stabilize the ipsilateral thorax. I will then palpate the subscapularis on the anterior surface of the scapula and apply increasing resistance of the distal humerus in the direction of shoulder external rotation. For shoulder internal rotation with gravity elimination, I will again place the patient in the prone position with their arm hanging off the table, and I will stabilize the ipsilateral thorax and palpate the subscapularis again. For shoulder external rotation and gravity resistance, I will place the patient in the prone position with their head rotated contralaterally to the side. Their arm will go in a 90-degree angle with shoulder abduction and flexion occurring, and I will assess the range of motion and stabilize the ipsilateral thorax while palpating the infraspinatus muscle inferior to the spine of the scapula. I will then apply increasing resistance proximal to wrist toward internal rotation. For shoulder external rotation and gravity elimination, I will place the patient in the prone position with their arm hanging off the side of the table. I will then stabilize the ipsilateral thorax again and palpate the infraspinatus muscle as well. For shoulder horizontal abduction with gravity resistance, I will place the patient in the supine position with their shoulder and elbow creating a 90-degree angle. I will assess the range of motion and stabilize their ipsilateral shoulder while palpating the pectoralis major inferior to the lateral third of the clavicle. I will then apply increasing resistance to the distal humerus in the direction of horizontal adduction. For shoulder horizontal abduction and gravity elimination, I will place the patient in the seated position while supporting their arm. I will then stabilize their ipsilateral shoulder and palpate the pectoralis major again. For scapular elevation and gravity resistance, I will place the patient in the seated position with their head turned away from the targeted area. I will then assess the range of motion and palpate the upper trapezius near the insertion point on the clavicle. I will apply downward resistance superior to the aspect of the acromion, as well as resistance to the anterior lateral portion of the occipital. For scapular elevation with gravity elimination, I will place the patient in the prone position and assess their range of motion, as well as palpating their upper trapezius near the insertion point on the clavicle. For scapular abduction and upward rotation with gravity resistance, I will place the patient in the seated position and assess their range of motion up to 125 degrees of shoulder flexion. I will then stabilize the ipsilateral shoulder and palpate the serratus anterior muscle on the lateral surface on the upper 8 to 9 ribs. I will then apply resistance overall over the scapula and the distal humerus. For scapular adduction and downward rotation with gravity resistance, I will place the patient in the prone position with their head rotated to the opposite side of the targeted area and rest the back of their hand on the gluteal region. I will then stabilize the contralateral thorax and palpate the rhomboids between the scapula and cervical thoracic vertebrae. I will then apply increasing resistance medially to the scapula in the direction of upward rotation and abduction. For scapular adduction and downward rotation with gravity elimination, I will place the patient in the seated position while stabilizing the contralateral thorax and palpating the rhomboids. For scapular adduction and depression with gravity resistance, you will place the patient in the prone position with their head rotated to the opposite side of the targeted area. You will then stabilize over the contralateral thorax and palpate the lower trapezius between the scapula and the lower thoracic vertebrae. I will then adduct the shoulder to about 130 degrees and assess their range of motion. I will apply increasing resistance to the lateral scapula in the direction of scapular abduction and elevation.
Parsonage-Turner syndrome is an uncommon neurological disorder characterized by the rapid onset of severe pain in the shoulder and arm. This is an acute phase that may last a few hours to a few weeks and is followed by the weakness of muscles in the affected areas. Parsonage-Turner syndrome involves mainly the brachial plexus, which is the network of nerves that extend from the spine through the neck into each armpit and down the arms. These nerves control movements and sensations in the shoulders, arms, elbows, hands, and wrists. Other nerves in the arm or even the leg can also be involved in Parsonage-Turner syndrome. The exact cause of Parsonage-Turner syndrome is unknown, but it is believed to be caused by an abnormality of the immune system. Some other inferred causes of Parsonage-Turner syndrome can trigger these cases, such as infections, both viral and bacterial, surgeries, vaccinations, childbirth, strenuous exercise, and connective tissue disorders or other injuries. There are a few characteristics of Parsonage-Turner syndrome. Initially, it is a sudden, constant, severe shoulder girdle pain. This pain will then extend into the trapezius ridge, upper arm, forearm, and hand. The pain is not positional and is usually worse at night and may be associated with awakenings from sleep. The pain is often described as a severe ache or throbbing radiating from the shoulder distally down the arm or proximately into the neck. The duration of pain is almost always self-limiting, lasting 1 to 2 weeks, but on rare occasions can last for longer periods of time. Sensory deficits, muscle weakness, and muscle atrophy are other characteristics that present itself in the clinical standpoint of Parsonage-Turner syndrome. Parsonage-Turner syndrome also has a differential diagnosis issue. This means that a lot of the times when these patients are diagnosed with other disorders, it's really Parsonage-Turner syndrome in its earliest stages. In the beginning, since the pain is situated around the shoulder girdle, it can present similar to numerous other shoulder problems such as rotator cuff tears, adhesive capsulitis, calcificate tendons, and arthritis. Weakness of the distal muscles can also occur, is that again presenting similar to other shoulder conditions such as tumors of the spinal cord, thoracic outlet syndrome, or cervical artery dissection. Treatments for Parsonage-Turner syndrome are various based on the signs and symptoms within each of the patients. Pain medication can be described depending on the severity of the nerve pain. After the acute phase, different medications known as co-analgesics may be administered. This includes gabapentin, carbamazepine, and adreptilophene. These drugs specifically treat the nerve pain. Other techniques for pain management include application of hot or cold and transcutaneous electric nerve stimulation, which is a method of pain relief in which a special device transmits low-voltage electrical impulses through electrodes on the skin to an area of the body that is in pain. A lot of Parsonage-Turner syndrome patients also undergo physical therapy or occupational therapy to maintain muscle strength and range of motion once the pain begins to subside. Surgeries such as nerve grafting or tendon transfer to restore movements and functions to the shoulder and muscle joints may be considered if the other treatment options aren't available.